motility disorder of esophagus. Okay, in that we have the following four main diseases basically: achalasia cardia, diffuse esophageal spasm, nutcracker esophagus, and hypertensive lower esophageal sphincter. Okay, so among the motility disorders, most common motility disorders of esophagus is achalasia cardia. Okay, most common hypomotility disorder is also achalasia cardia. So here what we need to understand is, if there is decreased uh, movement of food or slow movement of food, then that is also a problem. If there is fast and aggressive movement of food, that is also a problem. So esophagus should contract and relax at a particular rate. If there is slow motility, it is called hypomotility, and hypomotility disorder is achalasia cardia. If there is too much of motility, then that is hypermotility disorder, and that is called as nutcracker esophagus. So most common hypermotility disorder is nutcracker esophagus. Most painful motility disorder is nutcracker esophagus again. And for all these motility disorders, what is the investigation of choice? It is manometry, that is measuring the pressure in the esophagus. Okay, so now we'll start with individual motility disorders. First one being achalasia cardia. It is characterized by lower esophageal sphincter relaxation. Basically what we had discussed in the previous class, that is incompetence of the lower esophageal sphincter. ಅದೇ ಥರ ಈ ಡಿಸೀಸಲ್ಲಿ ಏನಾಗಿರುತ್ತೆ, ಅಕಲೇಶಿಯಾ ದಟ್ ಲೋವರ್ esophageal sphincter would be there will be absence of this relaxation. So basically it is always contracted. So whatever the food is there, it is not passing into stomach because this lower esophageal sphincter is not able to relax. Absence of relaxation. Okay na? And it is most commonly distributed both equally in males and females. So what is the pathophysiology here? We had discussed while discussing the anatomy of esophagus that there is absence of submucosal plexus, but myenteric plexus is present. Submucosal plexus is absent because there is no role of secretion here. But myenteric plexus or Auerbach's plexus ಅಂತ ಕರಿತೀವಿ. This is basically nerve supply, ಆಯ್ತಾ? So this helps in, this is present between muscle layers. ಇನ್ನರ್ ಸರ್ಕ್ಯುಲರ್ ಔಟರ್ ಲಾಂಜಿಟ್ಯೂಡ್ನಲ್ ಲೇಯರ್ ಇರುತ್ತೆ, ಅದರ ಮಧ್ಯದಲ್ಲಿ ನರ್ವ್ ಲೇಯರ್ ಇರುತ್ತೆ. ದಿಸ್ ವಿಲ್ ಹೆಲ್ಪ್ ಇನ್ ಮೊಟಿಲಿಟಿ. ಓಕೆ, ವಾಟ್ ಹ್ಯಾಪನ್ಸ್ ಇನ್ ದಿಸ್ achalasia cardia is, this Auerbach's plexus is present in esophagus and it has two types of neurons. One is stimulatory, which is responsible for contraction. Other one is inhibitory, which is responsible for relaxation. In case of achalasia cardia, this inhibitory neurons, whatever are there, they are lost. There is selective loss of only inhibitory neurons and excitatory neurons are present. Because of this, there will be contraction but no relaxation. Okay na? So basically whatever this myenteric plexus is there, it should have excitatory and inhibitory. So when this inhibitory is absent, there is no inhibition of contraction of this sphincter, lower esophageal sphincter. So lower esophageal sphincter will always be contracted, because of which the food will pass from oral cavity till the lower esophageal sphincter. But here this is not opening, because of which there will be accumulation of food here and reflux. So GERD manifestations ಇರುತ್ತೆ ಇವರಲ್ಲೂ. ಓಕೆನಾ? ಸೊ ಕ್ಲಿನಿಕಲ್ ಫೀಚರ್ಸ್ ಏನಿರುತ್ತೆ, unable to swallow, that is called dysphagia. And since he is not consuming enough food, or most of the food is not getting into the stomach and it is getting refluxed, because of which he'll be experiencing pain also while swallowing, so he'll reduce eating food, because of which there will be weight loss. And usually this dysphagia ಏನಿದೆ, it is more for liquid food than solid food. So whenever he is trying to drink, he'll be having more dysphagia when compared to whatever the food he is taking. Okay, so usually there will be a triad of presentation of achalasia cardia, that is dysphagia is okay, regurgitation, that's what I said, since the food is not getting into the stomach, it is getting regurgitated, and there will be weight loss. Okay, what happens if we don't treat this condition? What are the complications of achalasia cardia? Since whatever the food is getting reflux, it can enter into trachea and it can lead to aspiration. Hence there is increased risk of aspiration. And if this aspirate, tiny aspirate reaches the lungs, and if it stays there, then it will irritate the lung alveoli, causing pneumonitis, infection of the lung parenchyma. After that, it can become infected and it can convert into abscess. At last, it can become a risk factor for squamous cell carcinoma of lungs. Okay, so these are the complications. Basically, aspiration is the main complication. After that, it can lead to pneumonitis. After that, lung abscess. After that, squamous cell cancer. Okay, so this was about achalasia cardia. It is also a part of a syndrome called AAA syndrome. Aita? Syndrome is basically a group of clinical manifestations. In that, one manifestation is achalasia cardia. Along with that, if the person is unable to cry, or even if the patient is trying to cry, he is not getting tears. That is called as alacrimia. Basically, absence of lacrimal gland anta ankobodu ನೀವು ಆಯಿತಾ. Other than that, ACTH resistant adrenal insufficiency. These three, if it is present, it is called as AAA syndrome or Algrove's disease. Okay, it is just an association which is explained here. So okay, we got to know about the pathophysiology, about clinical features, about the complications. So how will we diagnose? What investigation should we do? Just like I said, for all motility disorders, we'll go for manometry. Measure the pressure in esophagus. Basically, lower esophageal sphincter, the pressure measure ಮಾಡ್ತೀವಿ. So what will be the findings of this manometry? In case if it is lower esophageal sphincter related, then there will be increased pressure because of absence of relaxation. If it is related to esophageal body, usually there will be absence of peristalsis and ineffective contraction, because of which there will be increased esophageal pressure. So if esophageal pressure, lower esophageal sphincter pressure is more, there can be two causes. One is related to achalasia, other one can be related to esophageal body. Okay, so one is manometry. Other investigation we can do is barium swallow. We will give the patient barium along with fluid like water, and we'll ask him to consume, and then while he is swallowing and when the liquid or food whatever we have given is traveling through the esophagus, we'll take x-ray, and on that barium swallow, how will this esophagus appear? So this is normal esophagus, and here is the lower esophageal sphincter. So lower esophageal sphincter ಏನಾಗಿದೆ, it is totally constricted, because of which only the food is able to, or whatever the liquid we have given, barium, is able to swallow like a string, or it is appearing like a bird beak like this. So hence this sign is called as bird beak sign or pencil tip sign or rat tail sign, whichever, like however you can imagine, you can say that sign. Okay, so on barium swallow, if you are able to see bird beak sign or pencil tip sign or rat tail appearance, then it is achalasia cardia. So there are two types of achalasia mainly, primary achalasia and secondary achalasia. Secondary andre pseudo achalasia. It is secondary to some known causes, like some cancer is there or some Chagas disease is there. Because of that, the lower esophageal sphincter is unable to relax. Okay, because of some other cause, not because of absence of inhibitory neurons of myenteric plexus. Okay, now if there is absence of inhibitory neurons of myenteric plexus, then that is primary achalasia. If there is some other cause which is leading to inhibition of relaxation of lower esophageal sphincter, then that comes under secondary achalasia. So how will we manage this? Yeah, basically calcium channel blockers. What this will do, this will relax the muscle, relax lower esophageal sphincter, hence calcium channel blocker is given. Otherwise nitrates, these are also vasodilators and they'll relax the lower esophageal sphincter. Otherwise Botox injections can be given, this will also relax the lower esophageal sphincter. Other than that, bogey dilatation or balloon dilatation, basically physically we can open. So what we'll do, this esophagus is like this, so we can insert a balloon and then inflate this. So this will physically stretch the esophagus like this. This will be balloon. After this, we'll take out this balloon and esophagus, whatever is stretched, it will remain. Aita? So lower esophageal sphincter by bogey dilation or balloon dilatation we can do. ಆಯಿತಾ. ಸರ್ಕ್ಯುಲರ್ ಮಸಲ್ಸ್ನ ರಪ್ಚರ್ ಆಗೋಷ್ಟು ಪ್ರೆಷರ್ನ ಇದರಲ್ಲಿ ರೈಸ್ ಮಾಡ್ತೀವಿ. ಓಕೆ, ವಾಟ್ ಈಸ್ ದ ಟ್ರೀಟ್ಮೆಂಟ್ ಆಫ್ ಚಾಯ್ಸ್ ಅಂದರೆ ಇಟ್ ಈಸ್ ಲ್ಯಾಪ್ರೋಸ್ಕೋಪಿಕ್ ಹೆಲ್ಲರ್ಸ್ ಕಾರ್ಡಿಯೋಮಯೋಟೊಮಿ. ಬೇಸಿಕಲಿ ಕಾರ್ಡಿಯೋಮಯೋಟೊಮಿ ಅಂದರೆ ಏನು? ಸೊ ದಿಸ್ ಈಸ್ ಈಸೋಫೆಗಸ್, ದಿಸ್ ವಿಲ್ ಕಂಟಿನ್ಯೂ ವಿತ್ ಸ್ಟೊಮಕ್ ಅಲ್ಲ. ಸ್ಟೊಮಕ್ದು ಡಿಫ್ರೆಂಟ್ ಪಾರ್ಟ್ಸ್ ಗೊತ್ತಿದೆ ನಮಗೆ, ಕಾರ್ಡಿಯಾಕ್ ಎಂಡ್, ಪೈಲೋರಸ್ ಎಂಡ್ ಅಂತ ಎರಡು ಎಂಡ್ಸ್ ಇದೆ. ಸೊ ಹೆನ್ಸ್ ದ ನೇಮ್ ಕಾರ್ಡಿಯೋ. ಕಾರ್ಡಿಯೋ ಅಂದರೆ ನಥಿಂಗ್ ರಿಲೇಟೆಡ್ ಟು ಹಾರ್ಟ್. So this is cardiac portion of the stomach. So this region is a lower esophageal sphincter. So cardiomyotomy is cardiac end of the esophagus, that is lower esophageal sphincter. Muscle is cut or it is extended. I mean muscle is cut, adana myotomy or opening is done in the muscle aste. Myotomy. Okay na? So this, since there is a contraction here, we have to relax it, and for that we are going for myotomy. And this can be extended till cardia or 1 centimeter of the stomach also. So till here it can be extended. This is the treatment of choice. Permanent treatment is. Rest all is just symptomatic. Okay. So after Hellas cardiomyotomy, we can go for partial fundoplication if needed, like DOR or toupee fundoplication, just like we had discussed before. Aita? So other newer techniques are being developed nowadays, that is called as POEM, per oral endoscopic myotomy. This is something related to notes anta karitare. There are surgical procedures being done through natural orifices. Aita? So oral cavity is one such natural orifice. So through per oral, by putting endoscopy, by per oral endoscopy, we can reach the esophagus and thereby perform myotomy, by which, because of this, laparoscopy alladrunu we have to create an opening in the abdomen or somewhere and then perform this surgery. But in case of oral endoscopic myotomy adre, already there is a natural orifice, and through that we are reaching and we are performing the surgery. So there is no surgical site infection risk also. Okay na? So that is the advantage of notes, that is natural orifice techniques. Okay, so that per oral endoscopic myotomy is a new treatment for achalasia cardia. Okay, in chronic cases, what we will do, there will be massive dilated esophagus, which is called as mega esophagus or sigmoid esophagus. In that case, we will have to remove the esophagus only. That is called as esophagectomy. Okay. Okay. Before starting other motility disorders related to esophagus, we should know the types of esophageal contraction. What are the types of esophageal contraction? There are three types: primary, secondary and tertiary. Primary andale enagutte, there will be progressive contraction. Gradually the contraction of the esophagus will progress, and it is usually triggered by voluntary swallowing. So we have consumed, suppose a patient has consumed food now, okay, and he swallowed it. So this becomes a trigger. As the food reaches the esophagus, there will be increase in motility. That is primary esophageal contraction. Okay, so food ಇಲ್ಲಿ ಬರ್ತಿದೆ, ಇಲ್ಲಿ contraction ಇರುತ್ತೆ, ಹಿಂದೆ ಮುಂದ್ಗಡೆ relaxation ಇರುತ್ತೆ. So because of contraction and relaxation, the food will pass down. Okay, ಈ ಥರ. So this is triggered by voluntary swallowing and it is a progressive contraction. Secondary contraction, it is also a progressive contraction, but here it is triggered by irritation or distension caused by the food bolus. So here it is also a progressive contraction, but this, whatever this food bolus is there, this will distend this esophagus. So ivaga imagine like this. So here is food bolus. Because of this distension, there will be secondary contraction. Okay, tertiary contraction andre, it is non-progressive and it is non-peristaltic spasmodic. This is pathological actually, not physiological. Okay na? So these two are physiological. These two, primary contraction and secondary contraction, is physiological and it will help in movement of food from oral cavity to stomach, whereas tertiary, it is non-peristaltic, it is not helping in any way and it is a pathology. Okay, so what is the blood supply of esophagus? Esophagus does not have its own blood supply. In the lower neck region, inferior thyroid artery iruttalla, that will supply the esophagus. Okay, in the thorax, behind the trachea, bronchial artery will be there, that will supply. Below T4, anterior to aorta, direct branches from the aorta will supply. And near the diaphragm, inferior phrenic artery, and near gastroesophageal junction, left gastric artery will supply. So basically throughout the path it is receiving blood supply from the nearby arteries. Okay, so next motility disorder of esophagus is diffuse esophageal spasm, which is caused by tertiary contraction, which is a spasmodic contraction. That's why I said it is pathology. Because of this contraction, there will be esophageal spasm basically, like there will be increased contraction and there is no relaxation, because of which this spasm can be so much that the blood supply itself can be cut off, and that can lead to ischemia of the esophagus. Okay, and then what will be the patient presenting with? He'll be presenting with left sided chest pain or pain in the lower part of the neck, which can be mistaken for angina. Right? So clinical features, just like I said, there is chest pain and there is dysphagia. What is the investigation we'll do for all motility disorders? We'll go for manometry. Basically measure the pressure inside the esophagus. So diagnostic criteria, if the amplitude of contraction when we measure is more than 120 to 120 mm of Hg, or if the duration of contraction is more than 2.5 seconds. Usually the primary and the secondary contraction is progressive and it won't sustain for long. Okay. Whereas this tertiary contraction, whichever is happening because of spasm, that will be there for more than 2.5 seconds, and if it is more than 2.5 seconds, it is diagnostic of diffuse esophageal spasm. Diffuse esophagus and spasm, name itself is suggesting everything. Okay, so what will we be able to see on barium swallow is this, like this corkscrew appearance. Because of contraction, because of motility, because of diffuse spasm, it will appear like corkscrew. Okay, so on barium swallow, if it is like corkscrew, it is diagnostic of diffuse esophageal spasm. It can also be said as pseudo-diverticular or rosy beaded appearance. Okay, what is the treatment now? Antispasmodics ಕೊಡಬೇಕು, calcium channel blockers and nitrates. Basically achalasia cardialo ಇದನ್ನೇ ಮಾಡ್ತಿದ್ವಿ. That was a temporary measure. Permanent treatment was Heller's cardiomyotomy. Here we should give antispasmodics. If there is no improvement, then we will have to go for esophagomyotomy. ಎಲ್ಲೆಲ್ಲಿ ಸ್ಪಾಸಮ್ ಆಗಿದೆ ಅಲ್ಲೆಲ್ಲ ರಿಲೀವ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಓಕೆ, ಸೊ ನೆಕ್ಸ್ಟ್ ಥರ್ಡ್ motility disorder of esophagus is nutcracker's esophagus. It is a most common hypermotility disorder. Okay, na? Increased movement of esophagus, and it is most painful. So what will be the clinical features? Chest pain and dysphagia. Investigation will go for manometry. And what is the diagnostic criteria? There in diffuse esophageal spasm, it was more than 120 mm Hg. In case of nutcrackers, it is more than 180 mm Hg, amplitude of contraction. ಅಂದರೆ ಯಾವ ಫೋರ್ಸಲ್ಲಿ ಕಾಂಟ್ರಾಕ್ಟ್ ಆಗ್ತಿದೆ ಅಂತ ಮೆಷರ್ ಮಾಡಿದಾಗ ಡಿಫ್ಯೂಸ್ ಇಸೋಫೇಜಿಯಲ್ ಸ್ಪ್ಯಾಸಮ್ಗಿಂತ ಜಾಸ್ತಿ ನಟ್ ಕ್ರ್ಯಾಕರಲ್ಲಿರುತ್ತೆ. ಹಾಗಾಗಿ ಇಲ್ಲಿ ಇಶೆಮಿಯಾ ಆಗೋ ಚಾನ್ಸ್ ಇನ್ನೂ ಜಾಸ್ತಿ. ಹಿಯರ್ ಅಲ್ಲಿ ಮೋರ್ ದೆನ್ 2.5 ಸೆಕೆಂಡ್ಸ್ ಇತ್ತಷ್ಟೇ, ಹಿಯರ್ ಮೋರ್ ದೆನ್ 6 seconds. Hence ischemia is more in case of nutcracker esophagus. Same treatment, antispasmodics and calcium channel blockers and nitrates. If there is no improvement, same treatment like esophagomyotomy. Basically based on this 180 mm Hg and more than 6 cm, and because of increased motility we are calling it as nutcracker's esophagus. So this was about esophagus. ಇನ್ನೊಂದು hypertensive lower esophageal sphincter, that is related to ಸೇಮ್ ಲೈಕ್ ಅಕಲೇಶ ಕಾರ್ಡಿಯಾ. ಹೈಪರ್ಟೆನ್ಷನ್ನಿಂದಾಗಿ ಅಂದರೆ ಸೆಕೆಂಡ್ರಿ ಕಾಸಿಗೆ ಬರುತ್ತದೆ. ಓಕೆ ಅಲ್ಲ, ಏನಾದ್ರು ಡೌಟ್ಸ್ ಇದೆಯಾ? ಓಕೆ, ಲಾಸ್ಟ್ ಕ್ಲಾಸ್ ಡೌಟ್ ಕೇಳಿದವರು ಹೇಳ್ಬೋದಾ?
ಇದ್ದಾರೆ.